Afternoon or good evening, good morning to some of our folks coming from overseas. We appreciate you all joining for another edition of our webinar series. We are currently a part of our Advanced Wound Strategies in Lower Limb Care webinar series, a specific subset of our overall NSWOCC and WOCC Institute webinar series in partnership with Perfuse MedTech, Gecko, and the Canadian Home Care Association. And I'm delighted to have back on with us Dr. Robyn Evans and Dr. Gary Sibbald, who we'll introduce in just a moment. But before we get to it, we'll do a couple little housekeeping items. First things first, let's pull up that chat button in your Zoom toolbar. I see some people are already there. Let us know where you're tuning in from, and maybe let us know what your involvement with wound care is. Maybe what type of healthcare professional you are, maybe where you work as well. That would be great. We're going to be recording today's session, so if you haven't had a chance to watch other webinars in this series, you can still do that at our NSWOCC.ca website. We have all of the webinars from this series and from other series on there, and we'll be recording today, so if you have to leave early or if you have a colleague you think that should be joining us, they can always watch it on demand afterwards too. You'll all be receiving a certificate of attendance, so please wait just about a couple days here. By Wednesday evening, we should get those into your inboxes. And the other thing I wanted to mention is we're going to be doing a Q&A session at the end of today's webinar. So if you have any questions, please do ask them, but use the Q&A button in your Zoom toolbar. So not the chat that you're using right now, but use that Q&A button and we'll get to as many as we can. We're also going to be doing some polls today, so keep an eye on your screen. You'll get a little poll button that'll pop up once in a while as we go through the slides. So with that said, I'm really happy to introduce our two guest speakers who will be talking about management of edema today. They are Dr. Robyn Evans, who has completed medical school and family medicine training at the University of Toronto with additional specialized training in wound care. She's the director of wound healing clinic at the Women's College Hospital, where she manages patients with complex wounds and has over 15 years of experience in wound care education and research. She serves on the board of Wounds Canada, co-directs the Wound Champion program, and continues to practice full-time as a community family physician, bringing an essential primary care perspective to edema and lower limb management. And we're also glad to have again with us Dr. Sibbald, who's a dermatologist and internist with special interest in wound care and education. He is a professor of medicine and public health at the University of Toronto as well, and is an internationally recognized wound care leader. He's the co-founder of the Canadian Association of Wound Care and former director of the Wound Healing Clinic at Women's College Hospital. A past president of World Union of Wound Healing Societies, Dr. Sibbald has authored over 200 publications and co-edited Chronic Wound Care 5. He currently serves as co-editor-in-chief of Advances in Skin and Wound Care and leads Project Echo Ontario Skin and Wound, supporting interprofessional wound care teams across the province. So we're truly privileged to have both of them with the evening, and I'll pass over the slides here to Dr. Sibbald and the team, and we look forward to the discussion today. Thank you both for being here.
Okay, let's go to the first slide. And my conflicts of interest with Project Echo, 50% of my time is with the Ministry of Health, and long-term care is actually separate. Chymoseptine takes us to the Philippines, and we have had, we'll be doing our 10th visit there in May. Perfuse Meditech is a sponsor of this, and I am co-editor-in-chief as the rest of the things you already know. Robyn?
Yeah, I think you just read through that. I'd just like to welcome everybody. I was looking at the chat and seeing people from Iqaluit and Fort McMurray, Vancouver Island. I hope the weather's nice somewhere. Pleased to be here, and thanks to Gecko for sponsoring the session that hopefully be educational and give you some pearls to take home. Next slide. Okay, so we want to define edema and consider what causes or what is the pathophysiology of fluid collection in the lower extremity, and then using the history and physical, examine and link this edema to the clinical findings. And most importantly today, I think it's about applying best practices to manage edema and prevent complications with specific review of the muscle pump activator and its clinical application. Next slide. All right, so we always like to know where everyone comes from. So if everyone just take a minute to click on what best describes your highest level of education or expertise. And this just helps us sort of fiddle with the slides and give you the best educational sessions.
Just maybe leave it for another second or two here. Again, thank you. Put in the chat there if you can't access your poll button, but I'll maybe share it now. I've got about 100 people participating.
Okay.
Perfect. And we're looking at about just over a third of participants, looks like, as a RN. Quite a few people as well as a RPN or LPN. Lots of NSWOCs, lots of skin wellness associates or SWANs, some nurse practitioners, and so on. You can see in front of you there.
Okay, so we need to understand what edema is, and this is a palpable swelling caused by expansion of the interstitial fluid. So if you look at that diagram on the right, you see the artery, the vein, and the capillaries, and the lymphatic system. These are the tubes, and in between that is the interstitium. And what's happening with edema is we're getting fluid collecting in that interstitium. So what I like to explain to patients is we've got fluid in the tissues, not in the tubes, which are the blood vessels, and this is the problem. Next slide. So why do we care? Well, edema is a bit of a problem for all of us in the lower extremity, and there's a number of reasons why. Next slide. I keep moving forward, Andrew. So the skin changes. Stasis dermatitis, that scaly appearance to the skin, is very itchy. Itchy skin causes further breakdown. It's a quality of life issue, and you get introduction of bacteria. Edema in its own causes distension. As you can see, the fluid's in that interstitium, not in the tubes, and it causes distension and discomfort and pain. Quality of life, you can go on and on about the quality of life issues related to edema, but just to name a few is my shoes don't fit, fluid leaks out of my onto my clothes, it's malodorous, but there's so many of these that impair a patient's quality of life. Lipodermatosclerosis is a big word for that woody fibrosis, that hard feeling of the skin that is very at risk for ulcerations, also uncomfortable. And when you get ulceration, you get this edema causes delayed wound healing just on its own. So if you have an ulcer with a lot of edema, you can expect to have poor healing. Infection is a big deal. Edema increases the risk of infection, and specifically, you can get athlete's foot between the toes, specifically between the fourth and fifth toe. Those two toes are very close together. It's a moist environment, it's warm, and you can get fungus growing in there. And that tinea can be the #1 cause of cellulitis in the lower extremity. Edema also increases the risk of mobility problems and is a marker of systemic disease. And we really can't forget to always include systemic disease as a cause. Next
and
slide.
I think the fungus, Robyn, to comment on that, will break down the keratin between the fourth and fifth toe. And that allows bacteria to start growing there, particularly Staph aureus, Strep, or Pseudomonas. And that bacteria, because the fungus has broken down the skin, can penetrate the lymphatics, and by retrograde spread, you can end up with the lower leg cellulitis or an infection. And if you're a person with diabetes, that could, and even anybody, that could be life-threatening or limb-threatening.
Yeah, it's true. And so this is a very common thing and something we should all be looking at when we check the feet between the toes. Very important. Well worth the effort. Next slide.
Coming.
Coming. Okay, so further to this, these are some of the examples of what you see with edema and what nasty events it cause. We talked about the stasis changes, damage to the skin barrier, the teniapedia that occurs between the fourth and fifth toe. In the middle there is a patient of mine who edema just got a little bit out of control. You got lymphedema in those tissues, and swelling and maceration and organisms growing. And this ended up not being fungus, but a yeast infection. So equally disabling and difficult to treat. Poor perfusion. Well, we know that if you have edema, you have blood vessels further away, it delays healing. The perfusion to the ulcer is poor. So reducing the edema will increase perfusion. And we know that edema also has its effect on fatty acids on the surface of the skin, which actually act as bactericidal properties for the skin to prevent infection. So edema is not a good thing in the lower extremity, and we need to really work to understand why it's there and what we can do about it. Next
I
slide.
want to comment, Robyn, just on the toe webs, that probably the best thing to put in the toe webs is povidone iodine 10%. And the povidone iodine will treat gram-positives, negatives, and anaerobes. It will treat yeast as well as true dermatophyte fungus or virus. And it also ends up drying the area. So after bathing, dry the area, especially somebody with this kind of swelling. Paint it in the toe webs with a Q-tip. And
Yeah.
I think it's interesting to know that 10% povidone iodine is available over the counter. You can get 100 mils for under $10, and that's going to last somebody if they're just painting it in the toe webs for quite a while.
Actually, what we did with this is we put actually Canestin topical liquid in between the toes here, and it worked really well to clean up the yeast that was growing there. But I could have also used povidone. But anyways, next slide. So to understand edema, we need to know a little bit about why it happens and what's going on in the tissues. So the diagram on the left, which shows you the heart. So the heart pumps blood in the arteries into the capillary bed. Fluid and oxygen and nutrients are exchanged there in that web of vessels at the bottom. And then the lymphatic and the venous system pull that fluid out of the area and back up to the systemic circulation. So that's the ideal situation. And how it happens is that on the right, you see the red arrow. That's pulling the arterial blood into the tissue, into the capillaries. So it's a bit high pressure because it's coming from the heart. So that high pressure allows the nutrients to go into the tissues because we want oxygen to get in there, nutrients to feed the tissues and nourish metabolic processes. As you go along that capillary bed, that pressure is dropping, but the oncotic pressure, the amount of protein, is now more concentrated, and it's able to pull the fluid back into the venous end of it. And where it's blue, the fluid should come back in. This happens pretty much reliably in the kidney, this Starling's law. But if you go to the next slide, what's really happening in the tissues and in the extremity is a little bit more complicated because the capillary bed is surrounded by a glycocalyx of glycoproteins. And actually, the fluid doesn't shift exactly as Starling's law. It's a little bit more complicated. And in this system, the lymphatic system also works to pull that fluid back up to the heart. So just be aware that we kind of forget about the lymphatic system, but should be more wary that this is also happening in the extremity. So it's the veins and the lymphatic system that are pulling fluid back out of the tissues into the tubes and back up to the systemic circulation. Next slide. Don't forget, though, we have systemic disease. We can't just concentrate on the lower extremity as much as we sort of get focused in on that because we're kind of there doing that stuff. But remember, there's big other causes. I think congestive heart failure you're probably going to see most of, where the heart is not working as well as a pump. It's not able to pull all the fluid back from the lung. Fluid backs up in the system, and you can get peripheral edema, congestive heart failure. Nephrotic syndrome is kidney disease, and in that process, proteins are low. And as you saw with the oncotic pressure or protein pressure, you can't pull fluid out of the tissues and it remains there. That's a big cause. Cirrhosis is the same thing. You can't build proteins because the liver is the big warehouse of protein metabolism. So when you have cirrhosis, your proteins are low. And again, you can't pull fluid from that interstitial fluid into the tubes. Gastritis, like in the form of Crohn's and ulcerative colitis, can cause also protein losing enteropathies. And there's other systems as well. But just remember, in your history, think about the comorbidities. As our patients age, there's often more than one. Next slide. So if we go back to the lower extremity and focus on what's happening there, we think specifically of venous disease, and there's valvular issues. So the valves work in the veins. So when the valves become distended, the valves don't close anymore, and fluid can go either which way. So you get fluid backing up in the system. And over the years, this can become quite significant. So people who get this are people who stand a lot, probably a lot of you nurses and RPNs and surgeons in working in hospitals, but also people that work on lines, factory workers, hairdressers. All of these people have been standing, not moving, and those valves are stressed over the years. Obesity, multiple pregnancies, and pelvic masses. All of this, again, downward pressure, but you can think of any cause of that. If you move on to what causes the blood clots, DVTs, that's damage to the deep system. Blood should go from the superficial veins through the perforating veins and up the deep vein system back to the heart. When you've had damage through a DVT, this system is not healthy anymore, and you can get more fluid accumulating in the tissues. Next slide. But the big ticket item here is edema related to failure of the calf muscle pump. And we're going to spend a lot of time talking about the implications of this. We have the gastro muscles in your calf along with the soleus, and those muscles work hard when your foot flexes and extends to move fluid out of the extremity. And its calf muscle dysfunction is a really strong predictor of venous leg ulcer severity. Lymphedema, similarly, and Dr. Sibbald is going to go on and talk a little bit more, but the picture on the right is a classic foot of lymphedema, collection of fluid in the tissues there. We can think of lots of causes of lymphedema. It can be due to infection, so anything that damages the lymphatic system, trauma, any injury to the leg can damage the lymphatic system, or post-surgical or radiation. Biggest example I think everyone is aware of is post-surgery after mastectomies and axillary node dissections, and you see that lymphedema that collects in the arm. So don't forget about this, and we think about what causes MSK problems. It's anywhere from the hip to the foot, and it can be related to shuffling gait, related to walkers, rollators, Parkinson's disease, anybody who has had a hip replacement, knee replacement, rheumatoid arthritis, any arthritis prevents that foot and ankle dorsiflexion. Look for these things, because if you look for it, it should fit with what you see clinically. So remember, it's a combination of both venous and lymphatic. Next slide. So the history is really important. I think if you don't know what's going on by the time you take the history, it's tough to find out exactly what's going on. So remember the comorbidities, think of the heart, kidneys, liver, and then the specific risk factors in the lower extremity for both venous and lymphatic, and also always consider the arterial. Dr. Sibbald and I have a talk coming up specifically on arterial and diabetes soon, so we'll delve into that a little bit more in detail. But the symptoms of venous disease are that heaviness, aching, itchy skin, restless legs possibly. Arterial, don't forget to ask, there's really only two symptoms: claudication, night or rest pain. So claudication is pain in the leg that occurs after walking a certain distance, and when you sit and rest, that pain goes away and you walk the same distance, and it's a reproducible pain. We're going to get into that a little bit later on, but just remember that that's something you should try to elicit, although it can be difficult because patients don't always walk, and they'll tell you that the reason they have pain is because of their spinal stenosis or their hip pain. Night or rest pain should really make you consider referral for much more extensive vascular investigation. And when a patient goes to bed at night, there's no longer a gravity pulling that arterial supply downwards, and they can get a lot of pain, and possibly getting up or like dangling their leg over the side of the bed makes it get better. And this is very concerning for arterial disease. Ask about the systemic symptoms. I know you don't have to diagnose cardiac disease, but you should know a little bit about shortness of breath, chest pain, breathlessness at night when you lie down, or waking up suddenly short of breath. Remember to know if it's acute or chronic. Chronic, slow-growing edema is a lot different from an acute system. Acute onset of leg swelling, always think of DVT. You always want to remember the thing that's going to cause your patients the biggest morbidity and mortality, and certainly never missing a deep vein thrombosis is very important. The distribution can be unilateral, bilateral. Again, most commonly DVTs are unilateral, acute onset. But remember that they can be bilateral in the right situation if a patient has a history of cancer. So always look at the history and the physical to remember to make sure you don't miss that one odd one that's sitting there, the red apple. It's not a deep vein. It's not a venous leg ulcer, but something else. Next slide. So the physical examination is really important. Always check for pulses. Even if you know pulses are great, it's good to get practice. It is the best and most reliable clinical skill that you'll get at the bedside to assess the blood flow in your patients. So you should be able to get very comfortable feeling the dorsalis pedis and the posterior tibial. Look at the joint mobility and gait, because that's going to give you a clue as to what is the calf muscle pump function. And then look at what you're seeing in the lower extremity. Does it fit with a venous problem, varicose veins, that hyperpigmentation or brownie or brawny discoloration of the skin represents red cell pigment leaking into the skin. The stasis dermatitis or eczema, atrophy blanche, which is more of a white discoloration, these woody fibrosis, and eventually you get this inverted champagne bottle deformity, which is kind of the late stages of venous insufficiency and hypertension. Lymphedema tends to be non-pitting, and often you'll notice a stemmer sign, which I know Dr. Sibbald has a slide coming up very soon. But remember with the pulses, try to practice those. You can grade them, but there's really no evidence for this. I think it's reasonable to say they're present or they're absent. If they're really hard to feel, I think you should be worried. And you should always feel a posterior tibial pulse. Next slide. Okay, Dr. Sibbald.
Right. The 2+ pitting edema in this patient is associated with venous disease, venolymphedema, lymphedema, lipedema. All of the above are answers 1 and 2. And although this is shown in the pretibial area, the early signs, the long saphenous vein is most superficial and greatest curvature on the medial aspect of the medial malleolus. So doing this test right above the malleolus, but obviously in this patient, there is quite significant edema. Okay, and let's look at the answers. I think the majority of you got this right, and it is answers 1 and 2. And I'll show you why in the next couple of slides. Next one. Okay, this is venous stasis with lipodermatosclerosis, and the woody fibrosis progressing to venolymphedema. When you have a mixed picture, you always put the first one first. And we know with venous disease, and as Robyn has outlined, the leakiness out of the veins produces the pitting edema. And there is a venous predominant component in venolymphedema. In pure lymphedema, though, you get the woody fibrosis and you don't get the pitting edema. And on the next slide, here's lymphedema versus other causes. It's a high protein edema, non-pitting, positive stemmer sign, and inflammation, fibrosis, and sclerosis. And when you try to pinch the skin on the dorsum of the second toe, you can't pick up the skin between the fingers, and then this indicates that it's lymphedema. This is a positive stemmer sign, but this may be positive with venolymphedema or with lymphedema on its own. Next. And lymphedema in the very early stage is reversible. Bed rest, elevation, no tissue changes that are permanent. We don't really recommend bed rest, though, although when you put the legs up in bed, it does help the edema to go away. The second stage is irreversible. It's hard to pit. The fibrosis is evidence. In the third stage, you get elephantiasis, or you actually get enlargement of the toes and in the skin, and you get gross skin changes and severe fibrosis. When you pinch the dorsum of the second toe and you cannot get the skin between the fingers, it is likely lymphedema. So that is the positive Stemmer sign. Next one. This is lymphedema with retention hyperkeratosis. And this kind of scale, if you hydrate it, you can much more easily remove it. You shouldn't really sit there with a blade or a curette and try to take it off, but just hydrating this will allow the scale to come off. And we know the stratum corneum has to have an 8 to 15% moisture content to be intact. And the natural moisturizing factors that cause that consist of substances like glycerin, urea, lactic acid, and, you know, there are very many humectant agents that will hydrate this kind of scale. Next one. This is lipedema. And lipedema is characterized by an increased layer of subcutaneous fat without alteration of the venous or lymphatic vessels. But again, you can get mixed disease where you may have more than one component. It's often in obese individuals with outflow obstruction, but it can occur primarily, and it may affect the arms as well. You also see here very well illustrated what's called the ankle fat pad sign, where you actually see the ankle, and this is soft, and the dorsum of the foot is soft. They can get secondary lymphedema, and so it would be lipolymphedema, and this can occur if you don't use very low compression on this in order to prevent any of the secondary changes. And even if people lose weight, the lipedema does not go away. Next one.
And that can be quite painful too for patients.
Yeah, and you really shouldn't put high compression on because
Right.
actually the arteriole, which is in the middle of the fat lobule and not in the septal part of the fat lobule, is very susceptible to that pressure. So when we look at a comparison, and if you want to take a picture of this, this is a good way to remember some of the key elements in this talk. Arterial disease is cool or cold, pale with dependent rubor. It's red when it's down, it blanches when it goes up. You may have thin, shiny skin, negative Stemmer sign. The loss of hair and thick nails is, there are 22 things that can cause nail disease, and even socks can cause hair loss. And capillary refill is greater than 3 seconds. But look for the dependent rubor, which goes away on elevation. Feel the foot, it's cold. And the other thing is, ask them when they walk, do they get pain in the back of the calf? And there are various levels, which you'll hear about in the arterial talk, the Fontaine classification, where they get pain at rest versus pain with a very, very short walk versus a longer walk versus pain that occurs only after walking quite a distance. Venous disease has an ambient, the last three, lymphedema and lipedema, have an ambient temperature. In venous disease, it may be hyperpigmented because when you have abnormal venous side of the capillaries or abnormal valves, you get leakiness of the red blood cells, which leaves behind hemosiderin and melanin. So you get the increased pigment. You can get pitting edema. And when you get the woody fibrosis, lipodermatosclerosis, Only a dermatologist could think of a name like that. But it just means it's like a tree trunk. The skin doesn't move, and they're less likely to get a positive pitting edema. And you have a negative stemmer sign. The hair and the nails are normal, and the capillary refill is less than 3 seconds. So when you push with your finger and you release it, you should see the blood flow coming back into the area you've applied the pressure. Lymphedema, ambient temperature, flesh color, or hyperpigmented. Woody fibrosis, positive stemmer sign. You can get that verrucous or wart-like change, the epidermis, and with the dermal fibromas, you can actually get things that look like little, if you like, little bubbles on the surface, but they're hard. And you can get hair loss with thickened nails with lymphedema, and capillary refill, because it's woody all the way down, is indeterminate. In the lipedema, you saw the flesh color, red hyperpigmented with secondary lymphedema, and that usually occurs in the gaiter area or the lower area of the lower third of the calf. And with this, you see a negative stemmer sign. Late progression may be positive, and that's when you get lymphedema. And the ankle fat pad sign, which you saw. And we also know that the hair and nails are normal, and capillary refill is less than 3 seconds. Next one. So the very first thing in venous disease is seeing a dilated saphenous or other veins. So you see varicosities of various sizes. Superficial varicosities and varicose veins often are associated with the lower leg edema. And we talked about various levels of pitting. When it's leaky to red blood cells, it leaves behind hemosiderin and melanin, and you get the changes on the distal leg, the hyperpigmentation. You see it very mildly on the left, and on the right, much more prominent. You get woody fibrosis, and this leads to the lipodermatosclerosis, and that's fibrin that is within the skin. And this is where wound healing and ulcers occur, and wound healing may actually be delayed with a lot of woody fibrosis. And that woody fibrosis can actually get inflamed. Next one. The changes around the malleolus of this patient are associated with livedoid vasculopathy, vasculitis, pigmentary purpura, superficial phlebitis, venous disease, are all of the above. And I would describe this as arborizing veins that appear to be radiating down from the medial malleolus in this patient.
Alrighty, and it looks like we've got a bit of a consensus here, so I'll end that and I'll share it in front of you. You should see it now.
Well, it's interesting. The actual correct answer is venous disease, and I'll show this to you in a few minutes. Livedoid vasculopathy has atrophy blanche, and it not only is around the malleolus, but on the dorsum of the foot, particularly at the base of the toes. Vasculitis is palpable purpura. So if you close your eyes, you can feel the spots and you see hemorrhage in the center. Pigmentary purpura is non-palpable, and it's diffusely down the lower leg. Superficial phlebitis is when you touch a prominent superficial vein and it's painful. And the superficial phlebitis can be associated with deep phlebitis in some patients. Okay, let's look at the next one. This is the CEAP classification that was updated in 2020. And often vascular surgeons use this more than wound healers. And I'm just going to show you the clinical manifestations, not go through the etiology or the anatomical distribution or pathophysiology. And C0 is no visible or palpable signs of venous disease. Telangiectasia are thread-like vessels, C1. Bigger varicose veins are C2. Bigger veins that are recurrent after some treatment, like sclerosing solutions or using, if you like, an electric current or actually stripping the veins. And they do come back. And C3 is edema, and changes in the skin or subcutaneous tissue secondary to chronic venous disease is C4. C4, A is the pigmentation, B is the lipodermatosclerosis, or what I described, the white areas, the atrophy blank. What you saw in that picture was corona phlebatica, and I'll show you that. C5 is a healed ulcer, C6 is an active venous ulcer, and C6R is a recurrent active venous ulcer. And Andrew, I don't see the recurrence on that one. Next one. So there are the spider veins. There are the varicose veins, which are deeper. You see some behind the knee, and you see some going down the calf as well as above the knee. Next one. Pitting edema of venous disease commonly extends above the knee. May be bilateral, most prominent over the pretibial region, usually persist overnight. All of the above are answers 2 and 3.
Alrighty, got lots of responses in now, and it looks like, again, we've got a bit of a consensus. I'll share that in front of you now.
And the majority of you are right. It does not extend above the knee, and it does not usually persist overnight. But yes, it may be bilateral, and it is often most prominent over the pretibial region. Next slide.
Can I just comment, Dr. Sibbald, that I think that that's one of the good questions for patients, for you to ask your patients. You're more likely to think of a systemic disease if it persists overnight. So you would want to ask more questions about that. It just makes it easy.
You see venous insufficiency with swelling, and you see venous insufficiency with the skin changes. You see the pigment, you see the red or the rubor from dilated vessels, and this is where moisturizers and topical steroids may help. Next one. And there's the corona phlebatica, and that's a starburst type of arrangement of the veins that go down from the malleolus. And if you start looking closely at patients, you'll see that this is fairly common, and especially as people age. And it is part of advanced venous disease. Next one. A recently healed ulcer is only 80% of the tensile strength of skin that's never been wounded. So C5 venous insufficiency with a healed ulcer, and C6 is venous insufficiency with an active ulcer. In the healed ulcer, you do see the darker change, the white scar, a post-ablation of the greater saphenous vein. That's above the dark area. And you see lipodermatosclerosis. And if stemmer sign is positive, then this would be venous lymphedema. Bandages for healing, stockings for maintenance. Very occasionally, we might use stockings as a primary treatment. And after 4 weeks, silver dressings are less effective. And that's been shown in a systemic review where they looked at the use of silver. And if you don't change somebody, and this would be the covert or the superficial infection with silver dressings after 4 weeks, you have to start looking at what's the cause and have I treated the cause? Have I optimized compression? Am I dealing with infection? Next one.
Okay, so management. Yep. Management involves education. And I think one of the things that we can all do, and I think everybody on this call remembers that there's lots we can do at the bedside. And one of the most important things I think is to educate your patients. And this should evolve over many visits. Compression evidence is considerable. I think we all know that. Leg elevation. This should be reinforced. And it's not as much to sit at your chair and put your legs up on an ottoman. You really have to have your legs above the heart or be in a recliner or recumbent on the couch with your legs elevated. Activate the calf muscle pump with exercises. Lots available on the internet. You can look at how to activate the gastro and the soleus muscles. Doing the diagram there shows some heel lifts, but there's a number of stretches you can do to do that. Even using resistance bands. This is something you can teach your patients at the bedside to use resistance bands to strengthen and get the calf muscle working. Skincare, moisturization, and we were talking before about drawing between the toes. And moisturization is an important part to prevent infection and nourish the skin, and of course, manage systemic illness. The other picture at the top is shoes. So patients need to be instructed, reminded that you have to have a good shoe to heel toe walk and get that proper activation of the calf muscles. So education regarding shoes. I often see patients coming into me after a hot summer in September complaining that they've got swelling in their extremities and they're wearing flip-flops. Well, it stands to reason, and if you explain it to patients, they're very happy to understand and feel that calf muscle. If you ask them when you ask them to dorsiflex and plantar flex their foot, put their hand on the gastro, and you can do it right now, and you can feel the pump of the calf muscle pump. When we moisturize the skins, we use humectants, which are like watering a plant. This is how I remember it. Whereas emollients are like mulching the plant. And I'll let Dr. Sibbald talk about that for a minute because I know this is one of his favorite things.
Yeah, and I think there are two kinds of moisturizers. So one kind of moisturizer is an emollient, and an emollient is something that actually prevents insensible water losses. And this may be something like petrolatum, Vaseline Intensive Care, Lipicar, etc. But the sternum corneum, as I mentioned earlier, requires an 8 to 15% moisture content. And since the 50s, cosmetic chemists have known the natural moisturizing factor contains urea, lactic acid, and a number of emollient modalities. And this is available when you put it on the skin to actually bind water. What you don't want to do, and you'll notice these are available, humectant moisturizers in lotions or creams. Why? Because they need the water binding sites open enough that it can bind water and help hydrate the stratum corneum. Anything else, Robyn, I should mention on that?
No, I just say that, patients often ask you what is the best kind. And I think going to the pharmacy and picking, pretty much anything without a lot of perfumes and other things in them is very simple. I mean, simply Vaseline is an easy, very cheap alternative as an emollient that can be put on at night. So there's many on the market. Next slide. So we want to bring this back to the consensus. So we want to practice best practice. And this is a consensus statement document that was initiated by Michael Stacy. There was a number of people on this panel and came up with a list of or a process for consensus for managing venous leg ulcers. Next slide. Right. So blown up in that one area that had a star on it, if the action is not, if you're not getting healing in your wound, so there's no size reduction in 2 to 4 weeks by 30% by 4 weeks, you got to think what's going on here. So remember to go back, review the diagnosis, make sure you're not missing some other cause for the ulcer or the edema. Assess the treatment protocols. Is what you asking to be done actually being done? Reassess the compression system. Is it being used effectively, put on appropriately? And review the exercise and walking regime. These are all things that everybody can do at the bedside, makes a big deal to the progress of the healing. Then we could add a muscle pump activator. And the muscle pump activator that we're talking about today is called the Gecko. And then always remember to consider referral for surgical management of some venous disease in the right situations. So quite simply, if you have disease in the superficial system and not in the deep system, there are avenues to provide surgical management for these. If you have damage to the deep system, really you don't have any other alternatives for surgery. But the way you would figure this out is to do a venous Doppler study, which is often ordered in your patients, to look at what is the reflux in these veins of both the superficial and deep system. Next slide. So when would you consider using a muscle pump activator? Andrew, you can go ahead and populate these. So we said delayed wound healing, that would be one option. When the blood supply is not great, intolerance to adequate compression or slow to heal wounds, patient-specific issues, leg shape can sometimes be a challenge for compression. Patients sometimes don't always tolerate compression. And pain is one of the newer reasons that for me for using the muscle pump activator. But you should know that there should be a reason. I don't think you're going to put it on everybody, but there are certain situations using the best practice guidelines that you're not getting healing because you can't get that fluid out of the extremity. The muscle pump activator or stimulator is an alternative. Next slide.
Okay, just before we go off there, suboptimal arterial supply. Those patients really do need a duplex Doppler to see if there's a bypassable, hard dilatable lesion, because that's still the treatment of choice. And after that kind of procedure, you may actually get reperfusion injury because the tissue isn't really ready for being reoxygenated. And that reperfusion injury may take a few weeks, and the Gecko may help you there, but certainly suboptimal arterial supply, just make sure the patient's not a surgical candidate or that
Yeah, I
the
think we're going to
patient
talk about
has
that.
refused it. Yep.
Yeah, next talk, if you come back, we're going to maybe spend some time on this, evaluating the arterial supply. But as Dr. Sibbald said, it's really the first line of defense is to improve blood supply, and that is getting more blood to the system, and that's usually through vascular surgery, if it's possible. But every once in a while, you get in a situation where it's not possible, say patients do not want to undergo any kind of surgical intervention. Next slide. So the Gecko. There are other options. I mean, the patient on the left-hand side with the big blue thing on their leg, that's a lymphatic compression system that you put on. You have to leave it on. It's a bit cumbersome. It does work reasonably well. It's very expensive. This gentleman actually bought that. I think it was about $5,000. So it's not an option for everybody. Muscle pump activator, which I have one right here to show you, is about the size of my wristwatch. Not much difference. It's easy to wear, and it is very useful as a muscle pump activator. Next slide. So it's about the size of a wristwatch. It's very light. It's battery operated. It can be used for 24 hours, so it's usually 12 hours on, 12 hours off, and then reapplied. Patients and families can learn how to use this. It is worn at the fibular head or on the lateral side of the knee. and it stimulates the common peroneal nerve to give a contraction that occurs once per section. So, and there are stimulating levels. So if you look at this, you see a plus and a minus, and you can actually increase and decrease the intensity of the pulse that occurs, and the patient can adjust that themselves as well. Next slide. So, and I would encourage everybody to look at Gecko and have a look at how to apply this. They show a video and it's really well done. So if you haven't seen it applied and you're wondering, look at the video. So here's a question about the Gecko. So which of the following statements is incorrect? Number one, decreases venous pooling and increases blood flow. Does it elicit a muscle contraction of the calf and foot? Is it contraindicated with a pacemaker? It is well tolerated, and a similar version appeared on the Shark Tank. How are we doing?
Awesome. I think we've got great participation here. Let's share the responses. You should see them in front of your screen now.
Great. Everyone's still awake. Okay, so the incorrect one is it's not contraindicated with a pacemaker. And I think that was a big question I had when I started using the Gecko, was that issue. It is extremely well tolerated. I haven't had patients take it off because of discomfort. And interestingly, there is a similar kind of version that was shown on Shark Tank, and a lot of sports teams use this for recovery of muscles. And I think the uses are just expanding. So that was kind of an interesting side angle. Next one. Okay, Dr. Sibbald.
What we're looking at here is the microcirculation of blood flow at baseline with Gecko. And on the left-hand side, you see the normal circulation. And when you turn the Gecko on, you're getting a twitch response, and you're actually increasing the microcirculatory flux with the Gecko device activated. And you get in the area of the wound bed a 225% increase and a 67% increase in flux to the peri-wound skin. So it really is, if you like, perfusing to a greater extent the foot and the lower third of the calf, which is called the gaiter area.
Can I just add that, so even if you have normal blood supply, or you perceive the patient to have normal blood supply, you're still getting improvement around the ulcer bed, which sometimes when you have that lipodermatosclerosis is you're really not getting a great amount of blood supply. And when you have venous stasis, you're actually getting a bit of venous ischemia. So the blood cells are just sitting there and it's not being oxygenated. So this is actually improving the local tissue supply of oxygen, even in patients with normal arterial flow.
Yeah, and on the other side of the coin, we know that exercise will actually help open collaterals. And it is possible that the Gecko, and we've had some patients with borderline arterial supply that have used the Gecko for a few months, and in the vascular lab doing the tibial brachial pressure, and that's not as influenced by calcification as the ankle brachial pressure. We've actually seen an improvement, and so that this 12 hours a day, 12 hours on and 12 hours off, may in fact help open up the microcirculation with the twitch response, etc. Next slide. This just illustrates the same thing. Okay, and this is the Gecko device activates lower leg muscle pumps. And you can see here the kind of activation that occurs within the vessels. And the baseline venous sludge index is 53.5. And with the Gecko device, it was reduced to 7.6. So you actually got increased movement. Next. Okay, this is the daily use of the gecko reduces the duration of hospitalization and improves early graft outcomes post-kidney transplantation, a randomized controlled trial. And this trial had over 200 patients involved in it. 221 were randomized. And when you look at the gecko device versus intermittent pulsed, if you like, an external device that actually pumps the blood, and as Robyn pointed out, they can be very expensive. But if you look at the leg edema, it was reduced by 2.5 centimeters versus intermittent pulse compression. You'll see that the outcome was 3.6 centimeters. So the gecko device, it was much smaller, more reduction in size. The weight gain was 4 pounds with the gecko, but 5 pounds with the intermittent compression device. The urine output was increased with the gecko over the device. You had higher femoral vein velocity with the device, and you had, when you looked at wound infections, the rate was 12% with the gecko and 20%. So these were patients all post-kidney transplant or post-kidney and pancreas transplant. And the results are really quite remarkable. And when you looked at incisional wound healing, 13% versus when you look at 29%, the length of stay 8.15 days versus 9.36. And when you look at mobility, the number of steps was better, and the cost savings were really seen with the device. So if you like, whether it's with or without compression, this is doing a good job. Next one. Here is the clinical trial in venous disease, and this was Keith Harding's group, where they admitted patients with venous disease to the study. For 4 weeks, everybody got compression. Those in the ulcers that weren't healing at the expected rate were randomized to continue with the standard of care, which was compression, versus compression plus the gecko. And between weeks 4 and 8, you actually got doubling of the healing rate with the gecko device. And after week 8, these patients all received compression, but no gecko. And at week 12 and week 16, the increased rate continued. And here you see the improvement in healing is really very marked within these patients, so that compared to the standard of care plus the muscle pump activator, 12 hours, 4 weeks of treatment versus the standard of care at the top alone. Next one. Okay, Robyn.
Okay, so I thought we'd just look at a case and see some of the situations where you might want to use something different based on the guidelines about healing and what you should do next. So this is a 64-year-old gentleman who stands on a production line 8 hours a day. He's using multi-layer compression system, and he reliably uses this. He does calf muscle exercises. He uses moisturizer. He has a history of a DVT, or deep vein thrombosis, in this leg, and he has very extensive lipodermatosclerosis. His problem is he heals, but he recurs with ulcers, and then they're a little, slow to heal. So what are the options? We can just discuss a little bit of where we would go from here. So we know he's not healing well. What would we do to try to improve the healing of that leg? Dr. Sibbald?
Yes, we're at time. Yeah, the first thing is from the inside out, I would consider pentoxifylline or Trento. It's a xanthine. It is fibrinolytic. It increases red blood cell contractility, and it is anti-inflammatory. So that's the inside out. From the outside in, I think you could consider the gecko along with optimizing the compression in this person. And of course, you need to treat pain if the pain exists, and you need to rule out other causes. Robyn?
Yeah, we did try Trentol or pendoxyphylline on this gentleman, and it actually wasn't very effective. He didn't really like taking it. He's also, he's an otherwise healthy guy, but he did do a trial of the gecko for a while when it was funded a couple years ago, and it did do pretty well to improve and maintain it to be healed. Next slide. This is the last case, and I know we're at time, but this is an interesting case because this gentleman has sickle cell disease. And if anybody here knows anyone with real sickle cell disease after many years, he's what, 54 years old. He's got a lot of issues with his hips and his knees and his shoulders. He get avascular necrosis. So he really cannot activate his calf muscle pump. He walks with a rollator or a walker, and he's quite bent over. He has almost no movement of the ankle by now. It's become very stiff. So there's not very many alternatives. And this is the newest gentleman I put on the gecko. He's had recurrent ulcerations, significant edema in his extremities. He tries to elevate, but not great all the time. And is actually his hematologist also contacted and got a big supply of geckos. So this man's our newest gecko guy, and I'm hoping for good things to improve the ulcerations and recurrence of his leg edema.
And I've got a similar patient, Robyn, that I've just started.
Yeah. So I think the real point is when you can't activate that calf muscle pump, this is one of the best scenarios, I think, to get the gecko on and try to get rid of that edema.
Yeah, and I think testing them in the clinic by putting, if you've got a gecko, putting it on and getting the twitch response and making sure that the patient tolerates it and they know how to put it on and use it is really a good thing. So you might, if you don't have any, bring them back and do that testing.
Yeah, I think he's had some nurses come into his place in the Niagara region. So he's had some training and hopefully it's working. I'm hopeful.
Okay.
So, alrighty, next slide. All right, we just one word about Lasix or furosemide. A lot of people you might find people that are on this for lower leg edema. Just remember you're using it for the right reasons. It's not really generally recommended for strictly venous disease. It's a systemic treatment, so it's taking water out of everywhere, not just your lower extremity. So it's taking it from the kidneys and everywhere else. So if you're going to suggest or see this and it's just for venous disease, make sure you're not using it for long periods of time and that you do check your electrolytes and kidney function. Use it with caution. And if it's strictly for venous disease, I don't think you should be using it long term. Dr. Sibbald? Anything else to say?
No, I agree with you. And I think that you really have to get away from diuretics. And if the edema doesn't go above the knee and there is evidence of venous disease, I think that the diuretics are not needed.
Right. Next slide. So take home messages. I think you want to link the edema to the history and physical. Spend some time with that history and physical. Ensure that you remember a lot of what Dr. Sibbald said about the physical findings. Educate the patients. This is a very important part. I think we're all in this to try to prevent further ulcerations, edema, and improve patients' quality of life. Remember to involve other healthcare professionals when you think there's systemic disease. Think outside the box. Remember, if it's not healing, think of other management strategies. And the calf muscle pump is a very important entity that we need to improve for our patients, teach to our patients, and apply compression appropriately. Next slide. I just want to highlight the NSWOCC conference. I realize it's coming up and there's a lot of information and studies and posters going on about pain, healing rates, which we alluded to today, microperfusion data, And that conference is coming up in April in Vancouver. So hopefully a lot of you can attend that. I'm sure Gecko will have a booth there and you can actually really try it and feel the buzz. Next slide. Thanks, everybody. I appreciate your attention, and Dr. Sibbald and I are certainly around to ask any questions.
Absolutely. And thank you so much, both of you, for your great presentation there. Got lots of great questions. And thank you for reminding everyone of the Congress. You can see my nice, beautiful Vancouver background, the QR codes here for it, if you do want to take a look. But yes, Gecko will be talking about improving clinical outcomes in leg ulcers with the muscle pump activator Gecko. And that Dr. Sibbald will be one of the presenters on that one too. Now we've got quite a few here. I know Jeff from Perfuse in the background has been answering some of the how to access Gecko in Ontario and then across Canada. I'm not sure if Jeff, you wanted to talk about that. I know it's past the hour, but if you wanted to address that, as there was a lot of questions about accessing Gecko.
Yeah, it really varies province to province, and in Ontario, which is where it seems like the bulk of the people are coming from, it got missed on the formulary for Ontario Health at Home. We're actively working with the government to get it relisted. Workplace Safety Insurance Board has enthusiastically reviewed the product. So for any workplace injuries, any types of wounds, post-op, pre-op, edema, for example, it'll be supported for that. Long-term care, we're working to make it more broadly available. In BC, it's on the formulary there. Alberta, we're working towards it. Same as Saskatchewan, Manitoba. Not available in Quebec yet. In eastern provinces, it's available. We're just setting some parameters on it.
Thank you for addressing that. And just so everybody knows too, we're going to be sending out a certificate of attendance as well as a survey in a separate email with this. And you can always reply back to that email if you want to get in touch with Gecko directly. We can do that. We had a lot of questions also about compression therapy, when to use compression, whether to use it in conjunction with Gecko. If you want to maybe just touch on that a little bit. And as a friendly reminder, one of the webinars we've already done in this series was called Compression Unraveled. That was also with our presenters from this series. It's available on demand on our website as well. But I'll pass it maybe to Dr. Evans if you wanted to touch on the role of compression and whether it can be used in conjunction with Gecko. And we might have just logged.
May be frozen at
We
the
might have
moment.
got frozen, so maybe I'll pass it to you, Dr. Sibbald, whether compression can be used in conjunction with Gecko.
Yes, it can. And I think it does enhance the effect of Gecko, but it isn't always necessary, as I showed in that post, kidney and kidney plus liver transplants. So that's the first thing. The second thing is that often in 80% or more of cases, it's bandages for healing, and it's, if you like, stockings to prevent recurrences. The bandages, there is a low pressure type of bandage, and there is a high pressure bandage. And that really applies to elastic bandage. And then there are non-elastic bandages like the NSWOCC, which may be very comforting for the patient if they've got secondary stasis dermatitis that works well, and if they have ulcers below the malleolus. And we do have videos on that previous presentation where the unapaced boot, and it needs something, a flexible, cohesive bandage on the outside to keep it intact. If they have a biphasic or triphasic wave on the audible Doppler, you'll hear about that in the arterial one, or an ankle brachial pressure index of 0.9 or greater, you can use high compression. That may be, if you like, it may be Coban 2. And then if it's below 0.9, you may want to use Coban 2 light. We have things that there was a 4-layer bandage that is certainly on many formularies still, gives high pressure at rest, and it is very awkward to get shoes on. And I think people have gone to different kinds of simple multi-layer bandages. When they go to stockings, you have to make sure they fit properly and that patients know how to use them. Those that can't tolerate full stockings, and 15 to 20 is the minimum, 20 to 30 often ideal, 30 to 40 with a lot of woody fibrosis or lymphedema, knee high. You often put a grip, fit it, and with or without toes. You can do zippers, you can do hooks to help patients get them on. But edema wear fits in nicely to irregular shaped legs and low compression. It's like a net, 80% of it's open, or you can use 2B grip, and in 2B grip with different lengths at the top, you can go up to 4 layers. I've said enough.
No, but I think that's really great. And again, for more information on that one, we do encourage you to check out that last webinar that we had done on compression therapy. A couple other questions we got here. Let's do this one. Is a ankle brachial pressure index required before safely using gecko? And in addition to that, can gecko be safely used in patients with mixed arterial and venous disease, especially those with a low ABI or TBI?
Yes, they can use the gecko with arterial venous disease or with borderline arterial disease. If somebody's got a lot of pain and critical limb ischemia, it may not be appropriate, but certainly we have saved toes and have been very successful in people where it wouldn't otherwise work. So I think, yes, we do have modalities and ways. Robyn, do you want to
Yeah, I
talk
kind
to
of
that
missed some
as
of that.
well?
My whole internet in this entire neighborhood just went down and I just tethered to my phone. So I missed a lot of that. What was the question?
Okay, it was really around using the gecko in arterial disease. And you have to be
Yeah.
careful, though, on the degree of arterial disease and tailoring your compression if you're using it to what the level of arterial disease is. And I would refer them back to our previous presentation.
Yeah, I think you need to tailor the compression and modify the compression if the ABI is less than 0.6. But factor in what your risk factors are and how much you really think arterial disease is contributing. If there's a big concern and you can't feel pulses, I'd be reluctant to put heavy compression on. I think light compression is a reasonable choice for almost all patients unless there's critical limb-threatening ischemia. But a good arterial evaluation at the bedside is critical. And I think that's be the focus of our next talk.
Okay.
And just for those who might have to head off here, just a reminder that we are recording today's presentation. I just put in the chat there too, if you want to watch a past one, whether it be that compression one we're talking about or some others. We most recently talked about pain and what were the other ones there? A lot on venous leg ulcers, dermatological pearls to optimize leg and foot care, and more. So do check that out there. Let's see if we can do maybe one more question before we go here. We had a couple different questions related to a TENS product or eStim, and could you just clarify the difference between gecko versus eStim for healing?
Oh. Well, go ahead, Robyn.
Well, I'll start with eStim, and you can do the TENS. How about that? We'll share. So eStim is electrical stimulation. It has nothing to do with activation of muscle pumps. So it's a current that, the electrodes on both sides of an ulcer, and a current is applied across there to either DC or AC currents. There is evolving evidence for eStim. My only concern with it is it's not readily available, and I'm not opposed to using it, but it's a very different use to a muscle pump stimulator. Nothing to do with muscle activation. Dr. Sibbald, you want to talk about TENS?
Yeah, I think though that to say, when we use the gecko device, we are stimulating muscle and we're not stimulating a really superficial phenomena. And I think that that's an important thing to say. And probably TENS is it's considered non-invasive and it's used to manage pain more than anything else. And it stimulates sensory nerves and
Right.
blocks pain signals. And it's kind of the theory of Melzack and Wall that we only process one predominant signal, and you're really creating a competing signal to the pain signal, and therefore you're decreasing the pain. But it's really not something that has been shown to increase wound healing.
Right.
And maybe one last one there too is we had a conversation about whether or when to use humectants versus emollients, and this is going to be in a topic in itself, of course, too. But we had one person who was saying that where was it here? That Vaseline or that petroleum jelly was not recommended; it wasn't breathable, and the client heard that from their doctor that it was not great. Here, let me get this question so I can actually ask it properly here.
You've asked it enough. You've
You've got the idea?
contextualized it.
Yeah.
And I think that what we need to say is what the patient will use. And not everybody tolerates ointments. And sometimes it's the rubbing action and the frictional resistant, and they may be dermatographic, and they may prefer humectants. If they've got open skin, though, and you put a humectant on it, it may sting and burn because it's attracting moisture that may come from the deeper skin. It doesn't mean they're allergic to it. But just be careful, whatever you use, that it doesn't contain perfumes, it doesn't contain lanolin, which in people with ulcers is a potent sensitizer. We sensitize more people with leg ulcers than anything. So be careful what you're using on our ulcer patients.
Yeah, that's a good point. The venous disease, you use a lot of products on these people and they develop dermatitis from a lot of these things.
Absolutely. And again, it's a great topic in general for wound healing. I know we could probably talk about it even more, but as we get towards the end here, I'll just do a quick reminder that we have quite a few coming up in this series. We have webinars on our site that you can see in front of you here going all the way into June. I wanted to flag one. We actually rescheduled the date. Dr. Stacy had to go into surgery to perform surgery right as we were getting on that webinar last time. So he regrets that he wasn't able to attend our last one in early February, but we luckily have a great option. It's going to be on Monday, March 23rd. Realizing there's a typo on this one. There's a webinar on March 23rd here on improving venous leg ulcer healing beyond compression. But we hope that you register for that. If you want to look for more upcoming, excuse me as I move around. If you want to look for more upcoming webinars, they all are on this site too, and you're going to be receiving a email by Wednesday with both your certificate of attendance, a survey, and the recording of today's session, so you can access all of that information there. With that said, we appreciate both yourself, Dr. Evans, and Dr. Sibbald for sharing your expertise today, and thank you so much to Perfuse MedTech and the Gecko device. We sincerely appreciate your support and in doing this entire series together. We hope to see as many people as we can on the next one as well.
Thank you, everyone.
Thanks, everybody.
Thank you.